Hi, I'm Dr. Jennifer V. Brown, your stroke specialist who's aging gracefully with a stroke diagnosis due to sickle cell disease. Today, we're going to discuss how you can get a longer stride or step length moving the hemiplegic lower extremity after a stroke. What you really need to do to get a longer step or stride on the hemiplegic side is to start at the pelvis. You need to make sure that it's a lower trunk initiated movement where you're rotating the pelvis forward, not hiking it up in the air. You also need to make sure that your hemiplegic leg starts behind the body. We call that a trailing limb. In order to get this position, you may have to do some preliminary work by stretching the hip flexors. Know that the thigh movement follows the pelvis. So when the pelvis is rotated backwards, your thigh should be backwards. But when it comes forward during mid swing, the thigh will come forward, causing the knee to follow the leg. And then when it's outstretched in front of you to prepare to get the heel on the ground, your pelvis is forward with the thigh. So how do I get this started in static work? I have the client start with the trailing limb, and I'm using the cane right behind his greater trochanter to guide that pelvis forward. All right. And when the pelvis is coming forward, I'm having his arm on that pole, and I don't want his upper trunk to move. I want it to be a lower trunk initiated movement. And then I have him pull backwards against that cane and then release it, and I guide it forward. Then we start doing some other more dynamic things with the pelvis. That work is usually concentric work, isometric work, and during the facilitated assisted work, that's concentric with lower trunk initiated movement. When going backwards, I'm resisting it with that cane because I'm trying to guide the pelvis backwards. So these are some dynamic things that I do. I have the client sit in a stool and I have them rotate side to side, but the upper trunk stays still. It's lower trunk initiated movement.
Oh, yeah. That's what I need to happen during gait.
Exactly. That's what I need to happen during gait. And here's what we're doing during standing. That pelvis has to rotate forward, lower trunk initiated movement. And then with that trailing limb, I can initiate the pelvis movement forward. And as that pelvis goes forward, you get passive knee flexion as the body weight rolls over the forefoot and the toes. Let's look. And so that's how I get that pelvis movement forward.
Oh, yeah. That's what I need to happen during
And
gait.
just a quick review. So, what are some clinical questions to ask? Is there a hip flexor weakness or a contracture with an anterior pelvic tilt? Because if you have an anterior pelvic tilt and contracture, your trunk may be coming forward in this plane, in the frontal plane, when actually you need it to rotate, all right, in the transverse plane. And initially, when you have a trailing limb, your hip flexors are on stretch, so it goes through a recoil. And then at the end of initial swing to mid swing, then you have that active shortening of the hip flexor to bring the thigh forward as the trunk, the lower trunk, rotates in that transverse plane. You need to understand the interplay of the hip rotators, abductors, as well as the trunk muscles, obliques, quadratus lumborum, erector spinae, and balancing the pelvis and facilitating forward pelvic tilt at the right time with the rotation. Remember, I am your trusted source for all things AFOs and stroke neurorehabilitation. These videos are up every Tuesday and Thursday. Subscribe and share them with someone. And don't forget about the references. Evidence-based practice to improve how we treat our patients and clients. Thank you for watching this video.